I do have some potential conflicts. I'll just give you a moment to look these over. I don't think a lot of them are relevant for today because most of them involve drugs, but I think it's important that you take some time to look these over. Apparently people don't show their COIs long enough, so I'm going to bore you to death with my COIs. Okay, so today we're going to be talking in the second part of the talk about reviewing changes in the screening recommendations. Han had referenced the fact that we've moved or changed the way we kind of diagnose patients with prostate cancer or patients at risk for prostate cancer. Understand the value of MRI, both in terms of the diagnostic care path, but also I'm going to show you a little sneak peek about some of the work we're doing in terms of adaptive radiation oncology. And to review advances, it's based on a talk I did a couple of weeks ago, but for many people who haven't been here very long, to kind of look back at the last 2 decades of treatment and what we've done to improve this at Sunnybrook and how we're impacting that for patients in Canada and around the world. So basically, I think breast cancer got it right, and finally we've caught up to breast cancer. So MRI as a second screen, if women have been screened with mammograms for as long as I've been in practice, and only just in the last couple of years, we've realized the value of imaging patients before we biopsy them. And I call the MRI in this setting the manogram. And I'll show you the data that kind of supports its use and the CCO guidance behind it. So we've done a lot of work at Sunnybrook and elsewhere. We're one of the centers of excellence around the world for image guiding research. And in terms of diagnostic imaging and imaging scientists, you can see on the top left a 2T image of a tumor in the left posterior zone of the prostate that corresponds with the whole mount histopathology specimen and ADC and diffusion weighted imaging maps. And there's different ways we can biopsy this, but using targeted approach. We have 3D fusion systems. This is just one of them, Artemis, which was developed in London and tested in a clinical trial that we had. But we find that actually just cognitive fusion is almost as good, and we're publishing some work on this right now, particularly if you can see the hypoechoic lesion that is visible on MR. So here you can see the dark area on T2 weighted imaging that corresponds to this hypoechoic region on ultrasound. So it's very easy to confirm the needle strike as you're doing a transperineal biopsy using this approach. So this is one of the 2 seminal papers that really changed the guidance for the work of men with high risk or at high risk for prostate cancer. And this was led by Lori Klotz. This was 453 men who were pre-diagnosis. They were randomized 1-to-1 with a systematic biopsy of their prostate if they had more than a 5%. So we used a calculator to figure out what their risk of clinically significant disease is. Like Han mentioned, we usually define that goalpost as Gleason 3+4. It's now called grade group 2 disease or higher. And men were randomized 1-to-1 to a systematic biopsy of the prostate or multiparametric MRI. And only if the MRI was positive did we target just the lesion. We didn't do a random or systematic biopsy. The goal of the study was it was a non-inferiority randomized control trial. We wanted to make sure and be confident that an MR guided approach was not worse by more than 5%. In fact, we actually found that it was 5% more likely to find clinically significant disease. Also important is that about 1/3 of men in the MRI randomized arm were able to avoid an MRI because they didn't have a visible lesion seen on imaging. And of those patients who were found to have what we used to call Gleason 6 disease, or what's now called grade group 1 disease, reduced by 55% from 22% to 10% using the MRI. So the MRI is more likely to find disease we need to treat, was less likely to actually result in a biopsy overall, and actually less likely to label men with a diagnosis that actually doesn't impact their life other than the anxiety associated with Gleason 6 disease and active surveillance. This resulted, this and the other study, the only randomized study called Precision, was really influential in changing the guidance. And I was part of this group at CCO that recommended that all men at risk for clinically significant prostate cancer who are able to have an MRI do this first in terms of their diagnostic workup. The future-looking part of me is thinking about MRIs and the limited capacity we have in the province of Ontario. And the really good news on the horizon is there seems to be a high-frequency ultrasound that is just as sensitive and specific as an MRI, but has a much lower cost, first of all, in terms of the purchase of the equipment, and lower barriers. You don't need specific MRI rooms with all the gas chamber outlets that Greg's been teaching us about on our recredentialing applications every year. So hopefully the exact view high-frequency ultrasound might be able to give us just as much information. And the other benefit of that is that we can actually biopsy the patients right there in the OR suite when we're diagnosing them, which is reducing the wait time. So if we put this all together, we might be able to improve how short patients wait in terms of from the time of suspicious PSA to the time that they actually get diagnosed and treated for their prostate cancer. So this is a much younger version of myself. This is 15 years ago. We were the first diagnostic assessment program in Ontario. This is at the Wright Prostate Center at Northern Toronto Hospital, which has just recently moved to Consumers Road just before COVID shut us down. And here is a map of all the DAPs for prostate cancer around the province. We did some work looking at how the DAP actually reduced wait times. The usual wait time in 2003 when we were thinking about this clinic was 8.2 months. After we had launched the clinic, the usual community workup wait times were 6.2 months from suspicion to the time of treatment. And with the Wright Prostate Center, we were able to reduce that by a further 2 months. And what I'm really excited about is a multidisciplinary approach using collaborators both in academia and in industry. The people who make Canada Arm and IBM are partnering together with Sunnybrook, Lawson, and McMaster to come up with IGAR. And I might have to work on the acronym a little bit, but image-guided autonomous robotic biopsies, both for breast cancer patients and prostate cancer patients, can reduce that workflow from 2 months down to 2 days. It's basically screening the patient, diagnosing the patient with MRI, artificially intelligence-informed readout, directed biopsies, and then pathology, AI-informed pathology readout as well. So this is a big grant we have going in through NSERC, and we're trying to get internal funding at Sunnybrook. But I think this has really improved the opportunity to diagnose patients earlier so they don't have to wait long periods of time. And that, if you ask any patient in that process, is really harrowing. What about radiotherapy? What's gone on over the last 20 years? How are things better? How are things different? So when I started, this is back in, I started in 2000. Just after I started, the standard approach was 66 and 33. We moved to 70 gray and 35 fractions. I actually adopted Eileen's practice, believe it or not. And she had a lot of patients with 70 gray and 35 fractions. Not a criticism, but how did the patients do in that era? More than 50% of patients with intermediate risk disease failed after 5 years. And you might say that's a good thing, that it's a bad thing, but I'll show you where things have come in the last 2 decades. So there is a series of studies that we did. These are small PDSA, Plan Do Study Act studies. And it was actually a joke between myself and Marlene Cardoso, who's actually retired now. She was an MRT. And I said, oh, I think we should have a catchy name, something that people would really remember. And she was, well, what are you thinking about? I'm thinking about, well, pea heart. And she's like, that sounds like fart. And I'm like, I'm going to call it that because everyone will remember that name. It's really going to stick, no pun intended. And anyways, whether you call it PHART or FART, the series now has 21 different iterations. The first one and the second one were launched by Patrick Chung when he was a fellow of Jared Morton. This is a slightly younger version of the two of them. And PHART1 was written up by Will Chu when he was a fellow here. I think in 2003 or 2004. Essentially, we took a 35 treatment program and we shortened it down to 31 using a very aggressive, at the time, 3 gray per day boost using IMRT and gold seed fiducials. And that was the first of its kind at Sunnybrook and one of the first of its kind in Canada. So remember again, the Lucas study where 50% of patients failed at 5 years, now we've only got 13% failure. So we're heading in the right direction. Patrick then shifted his efforts to high-risk patients and so came up with PHART2, which was basically a dose painting study. He gave a high dose to the prostate, which was equivalent to 8 weeks of radiotherapy using conventional fractionation, and 5 weeks of radiotherapy to the whole pelvis. He prospectively enrolled 230 patients, all high-risk disease. And you can see, despite the fact that they're higher risk, we're having the same disease-free survival or progression-free survival. 15% of patients are failing at 5 years. So really moving the goalposts forward. But what really changed things was what happened on 9/11 for a couple of reasons. All of us remember what happened, where everyone remembers where they were on September 11th, 2001, when the towers were hit. And I remember I was in review clinic, but Jared Morton, one of our leaders, was in the OR, probably didn't even know what was going on. And he was doing our first high dose rate brachytherapy implant. And now really setting the stage and setting the course for a new direction in the department in terms of the treatment of prostate cancer. He showed that 2 fractions of brachytherapy with 5 weeks of radiotherapy was equivalent to 1 fraction of HCR brachytherapy and 3 weeks of external beam radiotherapy. And really that changed the practice at Sunnybrook, across Canada, and at many centers around the world, in large part because of the strong fellowship program that we have here at Sunnybrook. We went on to look at stereotactic ablative radiotherapy, so a high precision form of external beam radiotherapy, using those gold siege and image guided radiotherapy that Patrick had put together back when he was Jared's fellow. We got this down to now 5 treatments. This is our Patriot data looking at the overall treatment time, randomizing patients between once a week and every other day. The once a week being the approach we use at Sunnybrook, and the every other day approach being the US approach. And really no difference. We did show, I don't have the data here, but we did show that there was significant short-term advantages for using once a week treatment, but long-term toxicity and long-term control rates were the same for both groups. Then the question is, can we do better? Can we go faster? Can we go harder? Can we do a higher dose per day? So pairing a pelvic immobilization device that was developed here at Sunnybrook with Harry Easton and Nant Ravi, myself, and Alex Nikolai, we tested the GU-LOC, which is that pelvic immobilization device, with 2 fractions of radiotherapy, giving the same 11-week equivalent dose to the prostate, but with only 2 fractions total. We found that there was a quality of life advantage in terms of small changes in bowel quality of life change, and significant advantages seen in moderate quality of life change for both bowel and sexual quality of life, which we all know is very important. Tamen just asked Han about his ejaculate research, and you'll understand why. We're now launching a phase 2 randomized control trial comparing these formulas. This published experiment was really hypothesis generating. So now we're trying to validate this with a proper phase 2 randomized control trial, of which Dr. Vesperini will be leading, called iSmart. So here's the march: 39 fractions, 25 fractions, 16 fractions, 5 fractions, 2 fractions. obvious that we should go to one fraction, right? One has got to be better since fewer fractions per treatment is better. Well, Jared Morton again showed us that we need to pause. We need to understand that just because we think it's better doesn't mean it's actually better. Randomized control trial using HDR brachytherapy, randomizing patients, one treatment versus two treatments, biological equivalent doses in the two arms, what we thought was biological dose equivalency, 5 times the greater risk of relapse. So in the 2 fraction arm at 5 years, 5% rate of relapse, same as our SBRT program, but now with 2 fractions. And single fraction had 27% chance of relapse. And I can just tell you as a clinician who's enrolled in following these patients, it doesn't stop at 5 years. They continue to fail 6, 7, 8, 9 years after treatment with the single fraction arm. I think the 2 fraction arm has leveled off. So we'll update that experience later, but it's really dramatic. And I think a single fraction is not appropriate therapy for patients. What about 2 fractions of brachytherapy versus SBRT? Dr. Correa, who's my fellow this year, or is working with me this year, showed that SBRT 2 fractions is just as good in terms of biochemical disease-free survival and actually has the same toxicity. It's cheaper, it's a non-invasive technique, uses less scarce resources. So we're hoping to test this prospectively, maybe in the CCPG PR19 study. Lastly, a big platform that Eileen's been pushing, and I'd love to get, and I will be getting behind this, and I'm very enthusiastic about it, is image-guided personal oncology or personalized oncology. So this is our first foray called EARTH. EARTH study is a combination of a single fraction of SBRT and a single fraction of MR-guided HDR brachytherapy. But the difference is we actually do an interval tumor response using high-frequency ultrasound based on the Zornada labs. They can actually image apoptosis in real time. This is done between the 2 treatments. And our imaging scientists with Dr. Bailey and Dr. Stanich has shown these novel MRI imaging sets where we can separate very clearly from certainly visually from a responder versus a non-responder. Red is bad in this situation. I don't understand the mathematics to go behind this, but it reflects true biologic changes. So you could see that we could do a single fraction of treatment, assess how that patient's doing, and then alter the second fraction depending on how that patient's tumor responds, either intensifying treatment or potentially even de-intensifying treatment. So this is very exciting, and we like to build on this as we move forward. This is just a snapshot of our first case of the EARTH patient, multidisciplinary team, really just like leading edge care. Like very few centers around the world have this access. I'm so grateful to be a part of this team. What about patients who fail radiotherapy? Even though I'm showing you that fewer and fewer patients are relapsing after treatment, it's still important for us to take care of those patients. And it's not just about systemic therapy. Hans is leading our Salvage HDR program, and Dr. Tagger and myself are now launching a Salvage SBRT program for patients with local recurrence after primary radiotherapy. And we're one of the larger centers in the world in terms of publishing this experience. So we're able to salvage probably between 50 and 70% of these patients. And I think novel imaging will help us identify the group of patients that are going to benefit the most from this. And if they do have true metastatic disease, this is where Patrick Chung and the rest of our group are leading the world, looking at metastasis-directed therapy, treating oligometastasis. There is some work that Alex Louie and David Palma have done showing that you can improve progression-free survival, but also overall survival. That study called COMET was had very few prostate cancer patients. It was only 16% of the patients enrolled had prostate cancer, and it's not clear whether they had state-of-the-art systemic therapies, because we now do doublet therapy, both ADT and an ARAT or chemotherapy for those patients. So we're now doing a randomized control trial. Patrick is the co-lead on this study called PR20 with Tamim Niazi from the Jewish General. 408 patients will be randomized to best systemic therapy or best systemic therapy and metastasis-directed therapy, either surgical or SBRT. And we're about halfway through the accrual, and I look forward to seeing those results and seeing Patrick at the podium at Astro presenting this data. So I'm really just wanting to share all the great work that Sunnybrook's done in the GU space. We've really helped redefine the use of MRI as a second screen. I hope I've showed you that modern radiotherapy has moved the goalposts forwards. It's more effective, it's more convenient, it's cheaper than previous treatment options. The radiotherapy is an important treatment option for recurrent and metastatic disease, but we need to test these formally before just adopting them into culture. But I think our group has been very good about not offering these treatments outside of protocol. I'm very proud of the fact that almost every single patient that gets radiotherapy in this space is on a clinical trial. And really, I just want to suggest that we continue to reinvent the future of GU healthcare. And I look forward to working with people like Han to integrate these novel biomarkers and detective tests so that we can actually be better, smarter, and faster in terms of how we treat patients with prostate cancer. It's often said that it takes a village to raise a child, but it takes a family to really move the goalposts forward on prostate cancer care. And this is just really a subset of the group of people who work and are passionate about making lives better for patients. And like I said, I'm super grateful to be a part of it and look forward to continuing to work with them. That's the end of my talk. Thank you.
Excellent.